Hey everybody, welcome back to the ECG channel. My name is Reed. Don't forget to download the PDF of this document down in the description below so that you can follow along and make your own notes, and subscribe to the channel if you enjoy. So let's get started. So let's look at the forest to begin with, and the trees of the forest are my QRS complexes. And so if I look maybe here in lead V1, you see I've got a wide complex rhythm that is occurring pretty regularly, and it stays regular throughout the entirety of the rhythm, right? My rate, if I find a QRS that lands on a solid line, maybe this one, see my rate is maybe 300, 150, 175, 60, 50, maybe 55 beats per minute, right? And it's, maybe there's a little bit of variation in the rhythms. If you wanted to maybe check other, QRS complexes here, you could see 300, 150, 175. This one's a little bit faster than 60. This one is like 62 beats per minute, right? So there is a little bit of variation between beats to beats. That can be expected. If it's a sinus rhythm, there could be something called sinus arrhythmia, which is variation in the rate based on inspiration, expiration, causing changes in your parasympathetic innervation to sympathetic innervation ratio of the heart. But let's verify that, right? We do see that maybe there are some P waves that kind of makes us think maybe there is some sinus arrhythmia. Those P waves are upright in lead 1, if you notice, and in AVF, they're also upright. So these are sinus P waves. So I would say likely is some type of sinus arrhythmia, but you're like, well, but Reed, we have a right bundle, or we have a right bundle. I just gave you the answer. We've got a wide complex QRS. This could it be a bundle branch block? Why is the QRS wide? Is it a ventricular rhythm? Well, we've got P waves before our QRSs, right? If you look, see we've got these nice P waves that occur before these wide complex QRSs. We said they're sinus P waves. The AV node, if you measure the PR interval, my PR intervals stay the same the whole time, and my PR intervals look to be about 160 milliseconds, which is in between 120 and 200. So that's normal PR interval. And I don't see any P waves without QRS complexes, right? If I scan through, make sure that there's no extra P waves hanging out anywhere, right? And so now it's time to evaluate my wide complex QRS, which you guys already know the answer for. Oh man, so you look and you can see it's wide, right? My QRS looks to be about maybe 5 small boxes, so that's 200 milliseconds. That's too long, right? We see 120 is kind of what we want. So when we see a wide complex QRS, the first thing that comes to my mind is if it's a sinus rhythm, which we've kind of identified, what's the bundle branch block? Should be your question, right? And so we'll change things up. We'll start off by looking for our left bundle branch block. So I look in the lateral leads, and I don't see any evidence of a left bundle branch block, right? But what I do see is I see these slurred S waves in the lateral leads. And that slurred negative force, that tells me that we have late forces going from the left side to the right side because they're negative in the lateral leads, right? You come over to these lateral leads here, which are leads 1 in AVL, and we get the same things, slurred S waves, right? So we have late lateral to left to right forces. So that makes me think that this is a right bundle branch block, right? Because if the right bundle branch is blocked, then signal that comes down from the AV node, right? We said sinus node beats to the AV node. When it comes down and that signal branches, it gets blocked at the right bundle, but it travels through the left bundle appropriately, depolarizing the territory of the left bundle quickly. And then in order to depolarize the right side of the heart, we get cell to cell, gap junction to gap junction propagation of that signal. And that takes a long time, so that occurs late. And look at the direction, it occurs from left to right. And so we get those left to right forces that are negative in the lateral leads. And then we get this nice RSR prime, right, in V1, RSR prime, right? We get the RSR prime. So really, we're seeing all the evidence for a right bundle branch block, right? So we've got a right bundle branch block. We're not done yet. Let's evaluate our QT intervals, right? It looks like my T wave terminates at least by that midway point in between my R to R intervals. So that's reassuring that my T wave isn't too terribly long. I look for pathological Q waves, looking for previous infarctions, and I look for ST and T wave abnormalities, specifically depression or elevation for active ischemia or infarction, and I don't see any. And so you put this all together, and what do you get? You've got a sinus rhythm with sinus arrhythmia in between, maybe 60 beats per minute or so, borderline bradycardia with a right bundle branch block. So remember, if you have a wide, complex rhythm, evaluate if it is a one ventricular rhythm, right? And you can do that by seeing if the QRS morphology doesn't match any of our normal aberrancies, right? So if it doesn't look like a left bundle, if it doesn't look like a right bundle branch block, maybe start to work through your algorithm of, okay, where is the atrial activity, right? And so then you're looking for atrial with aberrancy. So I hope that helps, right? Starting to slowly develop your frameworks for these rhythms. And if you have any questions, put them down in the comments. And if not, thanks for watching. I hope you have a great rest of your day, and we'll see you on the next ECG video.